Yes, so I'm really excited about this next part because this is where we get to hear from a couple of you guys. So we can't do what we do without you. That's absolutely clear. We rely on you to really be our boots on the ground and support us in this journey. So we did a bit of a call for action. We asked sites to come and tell us about the wonderful activities and all the endeavours that you have for recruiting into trials. And so I'm really thrilled to invite a couple of people up on stage. So first of all, we've got George Robinson. So George is from the West Midlands in the UK, and he first began his career in 2014 in cancer research, and then moved to Recognition Health in 2018. And this bit I'm really excited about to hear more. And under your leadership, you managed to recruit 95 patients in 5 weeks. So that is pretty outstanding. And you're currently doing an accelerated medicine course at Nottingham Uni. So thanks, George. We're really excited to have you here today. So,
pleasure.
Please.
Hi everyone. I know we're in that post-lunch bit of a lull, but I promise you this is a short presentation, so I should hopefully keep your attention most of the time. So the purpose of this talk is to really go into a bit of detail about what we've done at Recognition Health to engage with ethnic minorities, and also in general how we perform and how we recruit and identify patients. I want to start by just addressing the elephant in the room, though. I'm here to talk about ethnic diversity, and I'm a straight Caucasian male, probably the most generic individual to give this. But this presentation is an amalgamation of all of our recruitment team staff. It has input from everybody at Recognition Health to suggest methods we've utilised through the past and how we continue to identify certain individuals for this. The thing I just want to get started on, though, does anyone enjoy recruitment? Does anyone do recruitment? Do you call patients? Anyone? Do you find it difficult? It's a hard slog, is the point I want to raise. It's something that you really need a certain strong individuals to do the job. I'll allude to it later on the slide about the individuals we have that are the reason why we recruit successfully. But the point of this is really that there needs to be considerable efforts made and a dedication to the recruitment team, as well as the methods that you utilise. So the key steps we see to ensuring diversity in patient recruitment is firstly an ability to build trust and establish long-term relationships in communities. There's a significant emphasis on trust here and the long term. You can't expect a quick fix, particularly when it comes to recruitment of diverse individuals. We've done outreach programs with churches in and around communities. We gave free presentations advertised to the generic public to come and engage with generic memory studies and generic memory issues patients may have. And as a result of this, we've been able to just offer information to patients to really help them become advocates for their own health. We use direct advertisement as a large proportion of our recruitment methods, and social media is a big part of that, which we pick up on a lot of patients from. But one of the things that we probably need to utilise a little bit more is the offline messaging campaigns. In the past, we've used things like billboards, we've used bus presentations, bus posters, so patients can text in that see campaigns in local areas. But there's a need really to develop these offline messaging in key areas, in pre-identified areas of city centres, of the villages and towns that would have these lower socio-economic background individuals. And there's a point here about different languages too. I know the restrictions every site has in terms of the delivery of rating assessments in local languages, and English being one, but I think the use of languages, particularly in local language or local dialects for individuals, really helps build rapport and trust of patients to really engage with site and ask questions and start to build a relationship both ways. And then finally is the thing that we've particularly done at Recognition Health is we've developed racially and ethnically diverse investigator staff and employees. really to reflect the communities that we serve and to help build rapport and to see individuals that they can relate to when they come into centres with us. And on that previous slide is some of the events that we've done more recently. In terms of meet and greet, we've got things like introduction at community centres, at synagogues, at churches. There's a big acknowledgement, though, must be made to the cons to this, which of course is the costs. To employ somebody to attend that for a full day for likely minimal results. Unfortunately, it is what it is. It takes a long time to just get that first referral through, but that first referral can bring other individuals, and it's something that you can mutually gain information from. And one of the things we routinely do is ask other participants, what brought you to take part in this Alzheimer's study, or what brought you to actually engage with us in the first place, so we can learn lessons and develop relationships, which is one of the things that we brought in recently at Recognition Health, was someone with a specific role in patient retention to build relationships with patients that we currently have or used to have, to identify similar individuals to bring them onto trials. We have things like delegates outside shopping centres, supermarkets, to identify individuals, give out leaflets about the company we are and things that we can offer in terms of a vast amount of clinical trials that may be relevant, and free access to potentially disease-modifying medications, and the pros and cons to that. Then finally, we have the billboards, which I mentioned earlier on, and our bus campaigns that go around centres where individuals can text in, which have had some relatively small success, but there has been a small success there. In terms of offline marketing, I think the key take-home here, though, is that it's difficult to track and it's an expensive per lead compared to social media and digital advertisement, but it has an importance here. These are some of the strategies we've utilised to find these patients. Radio campaigns themselves have been quite successful, but I'm talking about, we've used things like Classic FM, which a lot of the patient demographic which we're talking about in this presentation won't routinely engage with. I think there's a need for us to identify, and radio companies will know this themselves about the average demographic of their users. And there's a slight advantage that it's a lot cheaper than your generic social media companies, but your generic radio campaign companies. But there's an opportunity there that I think that is our next step to move down. And our leaflet strategy as well, I think that this is a big point that sponsors need to recognise as well, that patient communication prior to consent is often overlooked. I know upstairs, and there was a lot of communication post-consent, your daily diaries, your study cards, information about the study visits. But getting that ethics approval for something to explain the mechanism of action of a trial, the pros to participating in clinical research, just the reason that you can withdraw at any point if you would like to, simple things that patients really don't understand unless they speak with a member of the recruitment team and invest that time themselves or take that step. And it takes a lot of confidence for them to do that, to pick up a phone or engage with us, but to really explain that. In terms of online marketing, what we've done, we've explored numerous methods of recruitment to reach all regarding this. You can see here there's some things that Dr. McSweeney routinely does, different webinars and explanations, holds presentations to the community. I've held webinars with her. We have a collaboration with, many people may recognise the social media influencer, Dr. Karen Rajan, now on ITV this morning. But we've had relationships with them to really promote the benefits of clinical trials and what this can offer in terms of disease-modifying medications, and break down the myths of what current options are available for patients, and of course the mechanisms of action of the acetylcholinesterase inhibitors and their usual duration that patients will see efficacy for. Then of course we have other things that I can't even include on this slide because there's so many. We introduced recently an online pre-screening method for patients to complete online, where they can have a rough idea if they're suitable for a trial. We've introduced cartoon explanation videos, which is usually about 2 minutes long, just explaining the process from coming in for your first maybe informal visit to have a chat with our doctor, to go into a screening visit, the MRI, amyloid PET scan, the likely procedures you go down. We even have a video explaining what study may involve a lumbar puncture and how to allay some fears regarding that. The other thing to mention is, though, that's really key to this is all of this is coupled with a team specifically trained to explain key concepts regarding these trials and regarding disease therapy areas we're in layman's terms and in certain words that these patients can relate to and understand. And then finally, I think this is my penultimate slide, recruitment itself, specifically diverse recruitment is difficult and it's time consuming. In the UK, there's certainly a lack of support at sponsor level. I'm not getting it right. I think every sponsor, there's sort of a lack of support, particularly in the recruitment of diverse and ethnic minority background patients. It's always mentioned as a priority or a requirement, but it's not formally stated how it's going to be given. It's so refreshing to see that being put at the forefront today, but it's really time consuming. The things that we really need from sponsors are either financial support, things like the employment of a full-time equivalent to engage in these relations, to build relationships in the long term, because this won't be a quick fix for the duration that we study for, the study's ongoing for. It will be something that will need to be maintained for a long period if we're serious about it. And the second is the investment in translational services and the ethics approvals regarding that. And I can't stress enough about the prior to study activation ethics submissions where we can put patient information out there to the public. I know every country is different. It's very strict in the UK, we find, to get something through ethics approved that will actually be eye-catching, will actually be informative, will actually allow a patient to think, oh my God, this is an opportunity I can't miss with my recent memory loss or my recent diagnosis of MCI. And then, of course, the endorsement of individuals in a certain ethnic group just comes from one of my team members of South Asian background. He sort of said to me, I can't see even my family engaging in clinical trials, and he works full-time with us. He worked for us for 5 years. And he sort of said, it would need somebody that my family trusts, someone that would endorse clinical trials, somebody either high in their community, whether that's a religious individual or whether that's somebody that they trust in a social setting. That was his only take home, that he could say that's the only thing I can see my parents actually engaging in a trial for. And then finally, this is just a look at our patient recruitment team. So I'm just the vessel to actually explain the positive things that we've done at Recognition Now. This is the team that actually book the high numbers of patients that we see across the therapy areas we do. And I always explain this to anyone that sort of says to me, how do you look for the most ideal patient recruiter and how do you find success in patient recruitment? And I sort of imagine a Venn diagram in my head. You have someone with an understanding of the scientific concepts in sort of any scientific background, but somebody that can grasp the concept. And then in the other circle, you've got somebody with a background in customer service. And it's where those circles overlap that really we find the real key, or the real individuals that can make a difference and reach huge amounts of individuals and engage in a way to build rapport and build trust in somebody to actually engage in not just their own health and the mechanism of action of a drug and Alzheimer's disease, but also to allay the fears and misconceptions people have around clinical trials themselves. But that's what we do. So thank you so much, everyone.
I just want to applaud you, George, for your previous slide, because your call to action and what you request from sponsors is so clear, and I'm really, really happy that you've developed this slide and that you're sharing it, because I really want to commend you for this. It's fantastic. And I'm really hoping that we can help you with a lot, if not all of these points. So thank you very much for calling this out. So here's George.
Thank you.
So next, I'd like to invite Rebecca Croucher onto stage. I know, just to let you know, me and Rebecca have been chatting for about a year now, Rebecca?
I think so.
Yeah, so we first met as Rebecca's day job as the UK NIHR Dementia Rater Programme Lead.
Yeah.
And as you heard about our Roche Rater Academy, that's how we started talking. And it's been a pleasure to collaborate with Rebecca for, well, it's well over a year now. So
Thank you.
I was really thrilled when we asked you to talk about all the wonderful initiatives that you're doing in the UK. And Rebecca, you are on the NIHR Clinical Research Network Study Support Lead and Senior Research Delivery Manager for Wessex. And you've also done a PhD in looking at multi-site cohort study that tracked patients converting from mild cognitive impairment to dementia.
Yeah.
So very well versed at talking to this topic. So thanks, Rebecca, and I'll hand it over to you.
Thank you, Ruth. Likewise, it's been a pleasure. Hi, everybody. It's a great opportunity to be here today, and I'm really looking forward to the conversations that we have with you later around the tables on this, because I'm going to talk to you about examples of how we try to increase our recruitment and provide research opportunities to those who are underrepresented in dementia research in the UK. So I'm going to give you some examples of that, but I know you all have your own from your own country. And some of the ones I'm going to talk about today, I know the UK site are going to be quite familiar with them because they are from your sites and others. And it was very reassuring to hear your talk, George, because I can see lots of similarities between what you've said and what I'm about to say. So that's always a good thing. Okay. Oh, no, I'm going too fast. So I just wanted to talk through a few things so that you understand the basis behind this set of slides. So when we talk about the UK and trying to increase that recruitment in underserved, it's a journey for the UK, and we are learning all the time, and sometimes we don't get it quite right, and we learn from that. But we've had some really successful strategies, and we're developing some really exciting initiatives that we're really excited to work with Roche on and others. So, and when I talk about underserved, we talk about different ethnic groups and gender and so on, but we're also talking about those that have different education experiences and attainment levels. We're talking about different social economic groups, those with different physical abilities, mental health issues that people might have. It's a wide net, and it really does depend on study by study of the population that their study is looking to recruit from, and it also depends on your location. So if you've got two sites in one large city, the underrepresented of one side of the city can be different to the other side. So I really do say and I'm sure you all do, is to take note of that study population and really get to know your local communities well, because that investment in the beginning to know who your local communities are will pay back over and over again. It will be quicker to work out who you're trying to work with and get better engagement with. What strikes me today for this study is that as these studies start looking earlier in the disease process, we're looking at potentially younger population, and those people may still be working. They'll still have other responsibilities like providing care for children, grandchildren, and so on. So it's about how we model our clinics and our visits, obviously adhering to the protocol, to enable us and enable that community who are still working or have other responsibilities to still attend visits. Okay. So I think, and I suppose in ways of inclusivity, I think what's really important is it's a net, and it's about how we widen that net and point it in different directions, depending on what study you're looking at and the population needed. Okay, so I have a few slides. There are lots of examples on it. As you can imagine, it's a very broad area to cover. So I'll go through it briefly. I won't talk about everything, but please do feel free to access the slides afterwards and have a look at those examples, and I'm around for the rest of the day. Okay, so I just wanted to show you what we're doing in the UK, just to give you a bit of contextual understanding. So the Department of Health and Social Care fund the NIHR. The NIHR is the National Institute for Health and Research. And as part of that support that is provided through the NIHR is regional clinical research network. So there's 15 regions in total, and those 15 regions' responsibility and objective is to support research, including dementia research in the regions. And all of those CRN regions, the 15, have teams. And in the UK, within those teams, we've got PPI leads, we've got specialty dementia leads that are clinically based, we've got dementia research delivery managers, workforce development leads, business intelligence, communication leads, and so on. And the reason why I'm giving you this is in the UK, there's lots of infrastructure, both locally and nationally. So there's already resource that you can tap into that I think even sometimes the UK sites don't always see, because I used to be one of those sites, so I am allowed to say that. And I certainly didn't realise. So there's all this expertise that's already freely available, and they want to work with the sites. And so I would say have a look at your own national and local infrastructure if you hadn't had a chance to really dive into that, because there might be something in this busy environment that we're working in that we've missed. And then again, as part of the NIHR, there are also a range of initiatives at a national level in the UK that is already going on, and loads of research has gone into it. And I've provided a few here, and you can actually access all of these online, so please feel free to go and have a look at what we've been doing in the NIHR. But there has been so much time and investment into understanding how we recruit to a wider net, and how we provide research opportunities to as many people as we can, and we will continue to do that. I wanted to flag the RATER programme, because we've got a UK one, and we've been working with Ruth and Adele and Roche on that, which has been a really nice opportunity. We've got the, and that looks to increase RATER capacity at sites, so they can recruit more, take on more studies, but also at smaller non-urban sites, so that we can increase research in that region. We've got the Include programme, that's a roadmap looking at intervention points to improve inclusion in research. We've got national recruitment registries, such as the Joint Dementia Register and the Be Part of Research, where we directly go out to public and ask them to volunteer to take part in research. We've got Enrich, that's looking at the care home end. And we've also got the Research Ready Communities pilot programme. There's quite a bit about that too. So again, in your own countries, there may well be things that you can tap into that's done a lot of the work already, because what I think is really important is we're all really busy and we can't do everything. So what we need to do is not recreate the wheel, see what's already out there and see what you can apply locally. Okay, so ways to promote research. Quite similar to recognition. We've got lots of things going on that the CRN support, and also that the research sites do themselves, and we work a lot in collaboration on it. We also provide research opportunities and promoting awareness through media, radio, other media arrangements and so on. And we look at, for example, memory cafes, coffee mornings, intergenerational education opportunities. We've been to a few music festivals and got very muddy in that process. And we've also partnered with our local communities, churches, faith groups, interest groups, and so on. So again, it's about knowing that community and what will work in that community. And then we've also looked in the UK at how can we recruit to studies outside of our traditional settings. So in the UK, it's from the large teaching hospitals that we tend to do commercial trials, and it's how can we expand out, so not to in any way to complement the big hospitals. How can we go further into the community and reach people that they don't necessarily come into the hospital pathway, or they don't engage with our National Health Service in the way that other groups might do. And here again are a few examples that I won't linger on too long. But for example, you can see some lovely pictures of some research buses there that have been designed, and I hear are coming this month or early next month. They've taken a while to create, but essentially they are going to be going out into the community in car parks with universities and other public areas, and we are able to do research recruitment on those buses. So like the pre-screener that was mentioned earlier, That would be great to do that. But we've also got other things doing, so brain health clinics where people go for additional screening assessments, and they can have an opportunity to hear about those research outside of the typical healthcare pathway. We've talked to pharmacies and providing training to third-year pharmacy students so that the people in the community, the pharmacists who are much more embedded within the public, can start raising awareness about dementia research. And for example, we've put study leaflets in prescription packages for people who are coming to pick up donepezil or whatever memory medication. So you can target it as much as you can. Okay, so just lastly, I wanted to touch on research connectors and the concept of that. And I think it's a really nice concept. Unfortunately, it's not mine. I would love to coin it. But essentially, they are the people that bridge the gap between you as a research site and the community. So, for example, they will be embedded within the community. They know the community. They're a familiar face. They know the trusted forms of communication and how information is disseminated. They know the most appropriate way to approach that community to talk about research opportunities. As researchers, we cannot do it all, and we don't have time to do it all either. So they are a great help, and they can be paid or not paid, depending, and we've got a few examples that I can show you in a second. They can, I think, what's really important about them is help you to be innovative and really creative, because when we're in our day job, it's hard sometimes to understand how that community would best receive that information and what they need from you in order to build that trusting long-term relationship with you, rather than you coming in, talking about a study, leaving, and then them not hearing how the study went or about anything else, so they're not building that relationship. Whereas those connectors can help do that and advise on the best way to do it. So again, as researchers, it's about us really respecting that lived experience and working collaboratively. So here is just a few examples of community connectors that I've heard about in the UK. So we've got actual networks, community networks, with embedded research champions, which I just mentioned. One site calls it Friends of that research site, which I think is a really nice term, and it takes us out of that research language that we're all used to. And we've also got CRN paid public contributors as well, which has been really successful in many regions across the UK. And then to take it another level higher, you could also apply it to service connectors. So for example, within the health and social care services around you, can you find someone to help you connect to find the best way to get referrals from those services, or to bring you in to talk about the team, or provide that information and get in contact with their service users or patients? And they can be charities as well, local authorities, interest groups, and so on. So once you get to know your community, and I'm sure many of you know of these organisations, is a really good way to look at it. We've also got in England multi-stakeholder groups developing regional dementia strategies, and being part of like living well, aging well with dementia, and so on. So again, it's knowing what the initiatives are. And it can be really hard to track all of these and work out where to best spend your time. Okay, I'm on the last two slides. Just some lessons learned so far from the UK. So the first one is your wider research infrastructure. As I said, it's been a really big journey for myself, who I think is quite embedded within our research infrastructure. I've done a lot of learning over the last few years to know what is out there, and there is so much good work already. Regional initiatives, again, what is happening around your region, not just within the health or the social care, but also in other charities and surrounding community organisations, and what can you pair up with to save yourself time and bring that as expertise together. And also think about when you're looking at things like socio-demographics, economic demographics, and so on. For instance, we see that relationship, don't we, where those with the most deprivation and hardship, the services based in those areas are more likely, certainly in the UK, to struggle with service capacity, workforce capacity, over burden of their services. And therefore, you might need to put in a bit more time, as in, so in the UK, for example, we've had people come and sit in on patient clinics to take away the burden from those services to help them get those research opportunities to their patients. Okay, last one. So know your community. I may have mentioned this a few times, but it's again looking at what your communities are, what they consist of, and it will differ for everybody in here. So it's really getting to know them and utilize those communication platforms that are already there rather than necessarily trying to invent our own ones. Let's jump on what's already there and we know works well, and finding that common language. So coming really out of that research environment, that health environment, and find language that they understand. I mean, I think when we talk to many people that I come across and I talk about research, many members of the public don't actually know what research means, but they don't want to ask. So it's really like taking it down a notch and coming out of our own jargon that we use so easily. Consider the location of your recruitment activity. So for example, I've given you examples of the bus, but you can also look at working in other community settings and so on, depending on your protocol. Different recruitment strategies clearly to reflect the different community needs and the diversity of the research workforce. So it's really great when a community sees somebody that is similar to them and will understand their culture and their experience in whatever group they are in. And that's, I think, where those connectors are really helpful and come in, whether they're paid or not paid, they can help do that. Okay, and lastly, engagement. So again, that reciprocal, ongoing engagement with these communities, finance the better, and identify who those local connectors are and really create a partnership with them where there's equal power. And I think that's it from me.
Okay, so thank you so much, Rebecca. And I really am grateful for both of you for putting yourselves out there and coming on stage to talk to us. And hopefully it's just sparked some interesting points for you to talk about locally. And you know, some of the points might not be applicable in your countries, but hopefully it's given you points for discussion.